Hello, this is Ken Covinsky from the Division of Geriatrics at the University of California, San Francisco and the San Francisco VA. It is great to be with you today for your journal club, and I'm thrilled that you're reading this really important landmark study that's really important for our field. So today, to help guide your discussion, I'm going to discuss three big picture issues, just very briefly, as questions that you might want to talk about as you proceed with your journal club. And I think all those of you who are thinking about this article may have additional issues as well. So one is what sounds like maybe a little bit of a wonky issue, but a very important issue in interpreting the study, and a very important issue if you're going to be a consumer of the medical literature. And that is, what's the difference between an efficacy and an effectiveness trial? So this is an effectiveness trial. And what does that mean in terms of your interpretation and understanding? So just very briefly, one way to remember the difference between these two terms is efficacy sounds weird. And that, in fact, is like a good way to think of it, because it's the way most randomized studies of interventions are done, and that they're very carefully calibrated to get the best possible look at the intervention. The investigator controls who's in the study. They control very closely how the intervention is carried out. It tends not to be necessarily close to real-world practice. So in contrast, effectiveness study is a study that's conducted in a real-world practice setting. So this was this study for fall prevention was done in a real-world setting of active primary care clinics across the nation. So effectiveness means real-world study where you try to show that you can do an intervention in actual real-world practice settings, but it comes at some cost because you deal with all the warts of the real-world practice. So, question for you to think about. Given the nature of this study and the hard world of real practice with the day-to-day realities, what aspects of real-world practice might have made it hard to actually to conduct this study? Is there something about how patients really work in the real world, the difficulty of carrying out complex geriatric multi-component interventions in the real world, that make this harder to do and might have led to a disappointing result that this study did not prevent fall-related injuries? Think about your own practices and the challenges you face when you try to implement complex geriatric interventions. So second question, one thing that was really different about this study from most of the larger fall prevention studies is most studies focused on the prevention of falls. So a lot of the successful studies that have shown that we can prevent falls just focused on, did you fall, yes or no? And fall injury was measured, but it was not the primary outcome. The reason for that is fall injuries are a lot less common in falls. So most studies that have been done have been underpowered to look at fall injuries because you just don't see enough over the course of the study. This was a huge study, so it was powered to look at fall injuries. However, you didn't see an effect on fall injuries. The study did not have a statistically significant impact on fall injuries. So what do you think about the difference between an outcome of falls and an outcome of fall injuries? Does it matter that we know pretty solidly that well-carried out interventions can prevent falls, but we're not quite as certain that we can prevent fall injuries? Can you assume that if you prevent a fall that you're going to prevent eventually fall injuries? Is there value in preventing falls even if we don't prevent fall-related injuries? Final and third question is, does this study present a challenge to the profession of geriatrics? We really like to believe in geriatrics at great geriatric care, and this was really a model of great geriatric care. It did all the state-of-the-art things we teach you in fellowship to do. do we need some humility that maybe we're not as good at preventing geriatric syndromes as we think? Do you believe that we can prevent fall-related injuries? Do you believe the evidence is there? What does it mean if we're limited in our ability to prevent geriatric syndromes like fall injuries? Should we be doing other things when we have patients at high risk for falls? So of course we're going to continue to do everything we can to prevent falls. But are there other things we should be thinking of? Are there things in the bucket of what we call palliation? So when you see a person who is at risk for falls, in addition to preventing falls, are there other things that go into your head that might be in the nature of quality of life, suffering, caregiver burden that goes along with fall risk? Should we be thinking about some of those palliative efforts in addition to preventing fall injuries? So those are my three big questions for you. Congratulations on this online and Twitter-based journal club, and good luck with your discussion.